So thanks for asking me to do this talk on transfusion reactions in hemoglobinopathy patients. This is the outline of my talk. So I'm going to go through the inherited anemias where transfusion may or may not be required, and then go through the principles of good transfusion practice, and then explain special requirements needed, particularly for sickle cell patients. And then I'll go through the different types of reactions, and I'll take you through the SHOT 2020 report with regards to hemoglobinopathy patients and transfusion reactions reported. So sickle cell disease is probably the largest hemoglobinopathy patient populations that we all see, and in many cases transfusion is required to treat or prevent complications of disorders, and it can be episodic transfusion for crisis management in up to about 90% of patients. But we are now getting to a stage in medical practice where we are planning regular interventions with transfusion, and at the moment it's lifelong transfusion support for many sickle patients with severe disease. So thalassemia is also another a big population of patients for transfusion requirements, and particularly those patients with thalassemia major who need lifelong transfusion support because their erythropoiesis is ineffective. Some patients with thalassemia intermedia may need some transfusions during their life, but this is episodic. And as we all know, beta thalassemia patients who've got the trait are mostly mildly anemic, but hardly ever need any transfusion unless something else has gone on. So the alpha thalassemias, hemoglobin H disease, which is 3 alpha gene deletion, these patients may occasionally need transfusion for symptomatic anemia, but rarely do they need lifelong transfusion. And again, the alpha thalassemia carriers are usually not anemic and don't need transfusion. So there are a number of other inherited hemolytic anemias, and these include the red cell enzyme disorders and the red cell membrane disorders. And for these patients, they may need episodic transfusion, particularly for severe hemolysis episodes, but it's not usually lifelong transfusion. However, the bone marrow failure syndrome, so Diamond-Blackfan anemia or congenital erythropoietic anemia, may require transfusion support, and this may be long-term. So good transfusion practice, I'm sure you're all aware of the 10 critical steps in getting the right blood to the right patient. And I've taken these figures from the SHOT 2020 report. On the right-hand side, in the diagram here, we've got 6 things that need to be in place for transfusion to be safe. And so that we need to have the right systems in place, so have the right space and equipment, and the resources with staffing and a culture of safety. The right blood component, we need to make sure that we've got safe, reliable and adequate supply. And with regards to actual personnel giving the transfusion and those people in the laboratory who are doing the testing, we've got to make sure that they are trained and qualified and competent. And then the decision making, we need to make sure that the decision making process is correct. We need to know that actually there are no other alternatives to transfusion, and this will benefit the patient and not put them at harm. And it's important to ensure that all the processes are in place to ensure a prompt assessment of patients should they have a reaction, and to make sure that we've got the diagnostic capabilities to undertake investigations. And really, this should be a patient-centered approach with good communication and with the expectation of giving the patient a good experience. On the critical steps here, you'll see that step 1, decision making, and step 10 are critical points in patient identification is absolutely essential. And really, step 10 is the final step to making sure that the patient has received the right component for them. The steps in between, so steps 4 to 7 are critical points in the laboratory where sample and request receipt, testing, component selection and component labeling has to be 100% correct. So what are we trying to achieve with transfusion? Well, the aim is really to improve the hemoglobin And by doing that, we improve the quality of the red cells, and this then suppresses endogenous red cell production. So by increasing the hemoglobin, we increase the oxygen carrying capacity of blood, and this improves the symptoms of anemia and improves exercise capacity. And given iatrogenic red cells means that the transfused red cells survive longer than the abnormal red cells, so the patient's own red cells. And we know that hemoglobin A red cells will not sickle when deoxygenated, whereas hemoglobin S red cells do. And in patients with thalassemia major, for instance, giving them a hypertransfusion reduces complications of expanded bone marrow and extramedullary hematopoiesis by suppressing their endogenous red cell production. There are some special requirements that should be met for sickle cell patients, so they should always be given hemoglobin S negative blood, as we do have people who are sickle cell trait who can donate. It's also important that if we've got a patient with a hemoglobinopathy, when they're pregnant, that if they do need transfusion, that they are given CMV negative blood. And also, if we do intrauterine transfusions, this has to be CMV negative. And any neonate who has had an intrauterine transfusion will need CMV negative product. For patients having transfusions, if they've got sickle cell disease, it should be less than 14 days old if it's sort of a top up, but less than 7 days old for an exchange transfusion. And really, we're aiming to increase the red cell survival and increase the transfusion intervals. There are occasions when patients with sickle cell disease who have multiple antibodies or rare blood that we may not be able to source all 6 or 10 units with specific for them, and sometimes the units are not always 7 days, less than 7 days old. So generally speaking, that sort of, when that scenario happens, we get a call at NHSBT to say, look, are you okay with 1 or 2 units being 8 days or 9 days old? And really it's a judgment call on the patient's need and what we are hoping to achieve. But that discussion does need to happen if those units for exchange transfusion are not less than 7 days old. And also, some of our younger patients with sickle cell disease who are recipients of stem cell transplants or about to go through stem cell transplants, we've got to remember that they will need irradiated blood components. And depending on what they have for conditioning, that radiated blood component need may vary, the duration may vary. So here are the definitions of hemolytic transfusion reaction. So important to note that acute hemolytic transfusion reaction generally presents within 24 hours of transfusion, whereas delayed hemolytic transfusion reaction occurs after 24 hours. And both there's an associated fall in hemoglobin or failure to sort of increment. You get a rise in hemolysis markers, so bilirubin, LDH, and you'll get a positive DAP. There is a condition called hyperhaemolysis, which is characterized by more severe hemolysis than delayed hemolytic transfusion reaction. And the hemolysis actually affects the transfusion red cells and the patient's own red cells, so that there is a drop in hemoglobin below the pre-transfusion levels, which is often associated with a drop in the reticulocyte count. So they have a reticulocytopenia. And it may be triggered by new red cell alloantibodies, but frequently we do not find new red cell antibodies. And hyperhemolysis can be divided into acute or delayed. So on this slide, I've got a list of all the transfusion reactions split up according to whether they're acute on the left-hand side, so those that occur within 24 hours, or delayed. On the right-hand side, those that occur after 24 hours. And for our sickle patients in particular, delayed hemolytic transfusion reaction and alloimmunisation is a problem. And for anyone who's needing transfusion, we must always remember that transfusion-associated circulatory overload, or TACO, is a preventable condition, and that all patients should be risk assessed for risk factors for TACO before transfusion commences, because the prevention is simple. So why do patients form alloantibodies, it's simply because they're exposed to red cell antigens that they lack, so they recognize it as foreign and produce an immune response to reject the red cell containing that antibody. And initially, the response is slow, so they're alloimmunized. And when they're re-exposed to the antigen, the response is quick and the red cells become hemolyzed. And this is where you get delayed hemolytic transfusion reaction. And we've got to remember that most donor blood is from a different ethnic group than the patient, particularly the sickle cell patients. And so they have a different red cell antigen profile. But there are some patients who never get alloimmunized, so those thalassemia major patients who start transfusion early, and those who we are able to give extended matched blood from the start. So detection of an early acute transfusion reaction is really important, and this is why we monitor the patient. We do baseline observations before we start a transfusion, and baseline observations are really important that they're recorded, because we need to repeat them after 15 minutes of starting the transfusion, as not all but most reactions, severe reactions, will occur within that 15 minutes. And it may be that the patient has a rise in temperature or a pulse or a fall in BP even before they start feeling symptomatic. And the symptoms depend very much on the cause, but can include fevers, rigors, flushing, vomiting, shortness of breath, pain at the transfusion site, loin pain, chest pain, and collapse are sinister signs. They can get itching or urticaria and also headaches. So it's important that we do that 15-minute observation, and then ideally we should repeat the observations hourly and then at the end of the transfusion, because there are some reactions that occur after the transfusion is completed. And if you do have a patient who's having changes in their observations or have developed symptoms, it's really important to get urgent review of the patient. So the next few slides, I'm going to go through some of the common transfusion reactions. So febrile non-hemolytic transfusion reaction occurs soon or during the transfusion, and it's generally a rise in temperature of degrees, chills and rigors. And it was very common before we leukodepleted blood, but now more rare. And really the treatment is to slow the transfusion or stop it, and some patients may need some paracetamol. And it's due to white cells releasing cytokines during storage. And often these symptoms can be mild or moderate. The allergic transfusion reactions commonly occur, especially with plasma, and you can get this mild itching or urticarial rash, sometimes associated with a wheeze. And this occurs during or after the transfusion, and usually slowing or stopping the transfusion is enough. Sometimes you may need to give some antihistamines to treat, and particularly in the future if they need repeat transfusions, to give it as a preventative measure. And the cause is allergy to a plasma protein in the donor, so it may never occur because you may never get a component from the same donor again. These allergic reactions happen more frequently in patients who have a tendency to allergies or atopic conditions. So this is the really serious one, wrong blood, which can be severe or fatal, and the symptoms and signs are of acute intravascular hemolysis. The patient may be restless, have chest or loin pain, fever, vomiting, flushing, collapse. And later on, they may have a hemoglobinuria. And they may present with symptoms and signs of shock, so drop in blood pressure, rise in heart rate, rise in temperature. Really here, you've got to stop the transfusion. You've got to check that the patient and the component is the correct component for the patient. And this patient really needs an urgent review. Samples for full blood count, urinase and coagulation are really important, because an ABO-incompatible transfusion can lead to DIC and renal impairment. And really samples should be sent for a DAT and repeat cross-matching. And often this is due to failure of bedside check when given the blood, and sometimes it can be due to wrongly labelled sample or a laboratory area, but often that final step that I showed you, step 10, where you're administrating blood, this is so important to do that step. So another reaction, bacterial contamination, can present with similar symptoms with shock, and it can be severe, but it is more common with platelets than it is with red cells. And it's due to bacterial growth causing endotoxin production, which causes an immediate sort of collapse. And this bacterial contamination can be from the donor, who may have had low-grade GI, dental, or skin infections, and it can be introduced during the processing. And as I said, it's much more common in platelets because they're stored at room temperature, as opposed to red cells, which are stored at 4 degrees. And at NHSBT, there are a number of preventative measures that are undertaken to prevent bacterial contamination, starting with donor questionnaire. So if the donor has any signs or symptoms of infection and they declare this in the questionnaire, then their donation will not be accepted. Arm cleaning, so at the site of the venipuncture, that area is cleaned for 15 minutes, and the first 20 mils are diverted into a pouch. Particularly for platelets, we take that off for bacti screening. So I've said red cells are stored at 4 degrees, and so they're less likely to be contaminated, but occasionally we do see this. There are some particular organisms that seem to favour the 4 degrees temperature, whereas it's much more common to see bacterial contamination with platelets, which are stored at 22 degrees. But we do bacti screening. So if there is a problem, we identify that, and if units have gone out, we recall them if they've not been transfused, and discard them. If they have been transfused, we make sure that the hospital is aware of the organisms that we found, and it's usually skin organisms, which for 99% of patients will not cause a problem. And it's important that when you are transfusing or starting a transfusion on a patient, that you look at the component for abnormalities, so clumps or discolorations or debris. And if there's any suspicion that the unit looks odd or not quite right, then it's far safer to send it back to the laboratory for a replacement than it is to go ahead with the transfusion. So here I've got a pool of platelets with, if you can see, there is a fluffy white cloudy appearance here, which turned out to be Staphylococcus aureus on culture. This unit was identified looking odd in NHSBT, and it never left the centre, and any associated units with this donation would have been recalled and discarded. So moving on to anaphylaxis, which can be severe and life-threatening, and it occurs soon after the transfusion, so very similar to sort of ABO-incompatible with shock symptoms. But here, the patient may be wheezy and have facial or laryngeal edema, which kind of directs you to an anaphylactic reaction. And the mechanism is IgE antibodies in the patient, which cause mast cell release of granules and vasoactive substances. Most allergic reactions aren't severe, but few can be, and they can be life-threatening. In IgA deficient patients, we do worry that sometimes, particularly when you get reports of severe anaphylaxis, about IgA deficiency, and actually the vast majority of patients who are IgA deficient don't ever have transfusion reactions. But if we do identify someone is IgA deficient, we can get IgA deficient products, but this needs to be planned and can take a few days. So in the first instance, if someone has had a reaction to platelets or red cells that is severe, allergic or anaphylactic, we'll start with washed products, and if that doesn't help, then we may go on to IgA testing, and we do have the ability to provide IgA deficient products. But as I said, it does take a little bit longer to sort of coordinate. So in an emergency, it's not something that we can do. So moving on to more common complications of transfusion. So respiratory complication is probably one of the most common, and TACO, or transfusion-associated circulatory overload, is the most common pulmonary complication, and it often presents moderate or severe and can occasionally be fatal. And really, if patient presenting with TACO, it just looks like someone with pulmonary edema, and giving them diuretics relieves the symptoms. This is the chest X-ray of someone with TACO. I've taken this slide from the SHOT report from 2019, which illustrates how common TACO is. So the blue columns here are TACO, whereas the orange columns are TAD, and TAD is sort of a diagnosis where it doesn't quite fit into TACO and it's not TRALI. The red columns are TRALI, and as you can see, TRALI is very rare. Usually we get 1 or 2 cases of TRALI per year. And it's 2020 report, I think there were 2 reports of TRALI. TRALI investigations take 3 months to come through. So in an acute setting, if someone reports that the patient has pulmonary complications, the first thing to do is think, well, is this TACO? And if it is TACO, they will respond to diuretics. Vast majority of TACO patients present within 6 hours, but the definition extends to 24 hours. TRALI patients don't respond to diuretics. So this slide just tells you that TACO is essentially pulmonary edema, and the patient will present with shortness of breath, drop in saturations, rising heart rate, rising blood pressure, and the chest X-ray will look like fluid overload. And really, we've got to make sure that we are doing an assessment on all of our patients before we start a transfusion, particularly the sickle population who may have kidney disease, who may have liver problems, who may have cardiac disease, who may already be on IV fluids for other things, who may be low in weight. So in this blue chart here, I've got all the risk factors for TACO, and the simple thing is to look at this, look at your patient and work out if they've got any of these contingencies. If they have, and if you need to transfuse them, think about how much volume you're going to transfuse, and you need to create some space to allow that transfusion to happen without causing TACO. You create space by giving them diuretics. So if you know what their fluid balance is, if they're already on IV fluids, if they're already in positive balance, you've got to give them some diuretics, diurese them, and then transfuse. And actually, wherever you can, think about a single unit transfusion, reassess the patient clinically or with laboratory tests, and then decide if further transfusion is needed. So I said that at TRALI, we do get 1 or 2 cases per year, and it can look very much like TACO, but the big difference is the JVP will not be raised and the patient will not respond to diuretics. And nowadays we see less TRALI because we are obtaining our plasma and platelets from male donors, so they won't have had been pregnant. And male donors, obviously all of our donors, we screen for them not to have received transfusions in the past. By doing that, we reduce the HLA-HNA antibody that are the cause of problems in many. So I couldn't really talk about transfusion reactions without mentioning infections, although we are much more sophisticated with our testing for hepatitis B, C. We also been testing for hepatitis E since 2017, and obviously HIV, HDL, V1. This risk is never zero. So really, this slide is just pointing out that actually, if you can do without transfusion, you should. There are some other transfusion transmitted infections. So if our donor says that they've travelled abroad, we will want to know where they've travelled, because we might do additional testing for malaria or Zika virus. The risk of variant CJD is low, and we don't have a specific test for that, other than sort of making sure that we don't take any donations for people who have previously been transfused. So for our very immunosuppressed patients and pregnant patients and intrauterine transfusions, we make sure that we give them CMV negative products. Also, for our hemoglobinopathy patients, it's important to note that parvovirus can cause temporary retroplasia, and so we try and make sure that that we screen for this if the patient has sort of a retroplasia that's not related to infections. So delayed transfusion reaction is probably one of the commonest things that we see in our sickle patients in particular, and it usually occurs 7 to 10 days after the transfusion. And you can have laboratory and clinical evidence of hemolysis with a positive DAT. We often do identify new antibodies or see antibodies that have been sort of at undetectable level, like Duffy and Kidd. Which, if we've not known that the patient's been transfused elsewhere and had these antibodies picked up elsewhere, they may have gone to a level where it's not detectable, and we've inadvertently given them blood products containing antigens of those groups. So hyperhaemolysis syndrome, it's severe hemolysis, and it's the condition that we dread in our sickle patients. They have a hemoglobin post-transfusion which is lower than the pre-transfusion, and both the patient and the transfused red cells are hemolyzed. And they can have a reticulocytopenia, and that is usually negative, although in some patients you do have multiple alloantibodies and some have autoantibodies. And really giving them more transfusions, particularly if they have, which you may need to think about if they're having a bad sickle crisis, exacerbate the condition. So ideally you want to try and prevent further transfusions in this group. So this slide is about transfusion-associated graft-versus-host disease, which we don't see very often now, but it's a condition which is basically 90+% mortality, and can present with severe diarrhea, liver failure, skin rashes of discoloration, or bone marrow failure. And really the prevention of this condition is making sure that we give radiated components to those patients who are very immunosuppressed, or those patients having HLA matched components. PTP, or post-transfusion purpura, occurs about 7 to 10 days after transfusion of blood or platelets, and usually resolves on its own within 4 weeks, but can cause life-threatening bleeding. And treatment is with IVIG. The iron overload is a problem for patients who are needing regular transfusion support, and it can lead to organ damage, particularly liver, heart, and endocrine. And nowadays, XJ, which has revolutionized how we treat these patients, is given pretty much at the onset of transfusion to prevent this. So moving on to some slides from SHOT, I think that there's a lot of learning that we can obtain from things that have been reported to SHOT, and particularly in reference to hemoglobinopathy patients. So year after year, the SHOT report shows that actually over 80% of incidences reported are errors, and vast majority are human errors. And on the bottom left-hand side here, you've got an iceberg, and you can see that year after year we do get a few ABO-incompatible transfusions, and we see sort of for 2020 it was 19, but below the surface there were 1,495 near misses of ABO-incompatible of the ABO-incompatible group. This slide takes you through the transfusion-related deaths for the last decade, so 2010 to 2020, which equals 173. And on the bottom slide here, the red shows the definite cause of death. So 1 cause of death due to delay in transfusion, and 3 probably due to delay. And with TACO, there were 2 probably due to TACO, and 16 were possible TACO-related deaths. The transfusion reactions, the vast majority are seen in red cells, and they're of sort of febrile reactions. And this slide shows you the reports on patients with hemoglobin disorders. So on the left-hand side, you've got the sickle cell patients, and there were 299 reports, and for thalassemia there were 64. And for sickle patients, you can see that incorrect blood component special requirements not been made is the vast majority, so 37.5, followed by hemolytic transfusion reactions, and the two together almost make up to 73% of the reactions. Whereas for thalassemia, you see that febrile hemolytic reactions account for the vast majority in the orange, followed by incorrect blood component special requirements not met, and together the combination comes up to almost 44%. So I'm going to take you through some of the reports now. So for delayed and under or over transfusion, there were 4 reports. 3 were of delayed transfusion, 2 occurred in patients with sickle cell crisis. 1 was for a routine transfusion in a patient with thalassemia. And there was 1 report for over-transfusion in a child with sickle cell attending for a routine transfusion. There were no avoidable transfusions reported for 2020. For incorrect blood component specific requirements not met, there were 15 reports, 14 of which occurred in patients with sickle cell disease and 1 in a thalassemia patient. For febrile, allergic or hypotensive reactions, there were 9 reports. 4 were reported incidents in children with transfusion-dependent thalassemia, who each developed fever, rigors, back pain, chest pain, loin pain, and all were thought to be non-hemolytic transfusion reactions. There were 5 reports of non-hemolytic transfusion reaction in sickle cell patients with symptoms reported including fever, rash, and pain. And in all of these cases, there was no report of serological incompatibility. For hemolytic transfusion reactions, there were 15 instances, all occurring in sickle cell patients. 9 of these were reported as hyperhaemolysis, 5 were delayed hemolytic transfusion reaction, and 1 was an acute hemolytic transfusion reaction. For incorrect blood component, wrong component transfused, there were 2 reports. So case 19.2 was a case of a young patient with sickle cell anemia who had an exchange transfusion in 2014 without being tested for extended phenotype. And then 6 years later in 2020, the patient was given another exchange transfusion. The patient had an RO phenotype. However, the units transfused were only matched for ABO and KEL type. And following the transfusion, the patient showed signs of hemoglobinuria, jaundice, drop in hemoglobin, and anti-Big C and Big E were detected in the post-transfusion sample. Case 24.2 was of a sickle cell patient, a young female, who attended for a routine transfusion. The infusion pump was set up incorrectly and an over-transfusion. And here the staff member was not familiar with the local policy and the prescription was not checked. And the error occurred during the transfusion when the pump was reprogrammed. The patient was reviewed after the incident, and thankfully no harm was reported as a result of the overtransfusion. The next case was a woman with sickle cell disease who received a 2-unit transfusion, and following this, the laboratory staff noticed that there was a discrepancy between the genotyping result available on SPICE and the phenotyping results on the limbs. The reference laboratory had found an Rh variant Big C and little E antigens, and these genotyping results had been uploaded onto SPICE, but the local laboratory had not been informed via a letter. And prior to the discrepancy being noted, the patient had received red cells matching the phenotype and subsequently developed anti-Big C and anti-little E. And so here, this case demonstrates the importance of specialised results being communicated to the requesting team as well as being available on the SPICE system. So case 24.4 was of a patient who was admitted outside his local area with an acute pain for crisis and transfused because he dropped his hemoglobin. The patient was aware he'd had red cell antibodies and asked the medical team to ensure that he got the appropriate blood. The laboratory team did not see the clinical information on one of two group and antibody screen requests, indicating that the patient had historic alloantibodies, and therefore the patient did not receive antigen-negative units. This was categorized as a laboratory error, but when you think about it, clinical and laboratory teams have a shared responsibility to ensure that the patient receives the correct blood. And where the patient is not known to the local hospital, it would be safer for the medical team to talk directly with the laboratory. And the laboratory can talk to the hospital that the patient had previously transfused, sort of a direct discussion between laboratory. And this case just highlights the importance of ensuring patient involvement and good communication between clinical and laboratory teams. So this case is of a young child with sickle cell disease who was transfused, hemoglobin was 71 grams, and the indication of transfusion was documented just as anemia. The request form stated (?) sickle cell disease. The laboratory team failed to flag this potential diagnosis, and therefore the patient did not receive RH and KEL matched units. And this really demonstrates the lack of understanding of the relevance of sickle cell disease in transfusion practice. The patient's baseline hemoglobin was unknown, and nor whether there was a clear indication for transfusion, particularly as the requester did not seem to be clear of the diagnosis. And although the diagnosis on the request form was ambiguous, the laboratory team should have contacted the clinical team for clarification. So the next case is an example of a D variant leading to difficulties with matching. So a young child with hemoglobin SS was admitted to a hospital outside the local area with a sickle crisis with a hemoglobin of 51 grams per litre. The blood grouping for D showed a dual population of red cells, and the group was misinterpreted as D positive as the population of D positive cells looked greater. The D group could not easily be confirmed on standard phenotyping. However, the BMS thought that the patient was D positive and issued 2 units of red cells, both of which were D and E positive. It should be noted that laboratory policy is that where D status cannot be determined, D negative red cells should be given. In this case, on the following day, the SPICE record was checked, which confirmed the patient to have a D variant. And according to the blood service report, they should have received D negative, big E negative, little e positive blood. In addition, one of the 2 red cell units given were not hemoglobin S negative. The child was followed up for development of an antibody. This case demonstrates that despite extended RH matching, alloimmunisation is further complicated by significant genetic heterogeneity in this blood group system in individuals from Black, African or Afro-Caribbean ethnic backgrounds. And variant RHD and RHCE alleles can result in altered D, C and E antigen expression, which may incorrectly be identified as positive or negative on serological or phenotyping. And so in such cases, genotyping is really useful to confirm the RH variant. The next case is of an ABO-incompatible transfusion in a sickle cell patient who was group O, who was given blood intended for a different patient. So 2 units for 2 different patients were incorrectly checked only against the electronic prescriptions. The nurse set up the blood transfusion for the sickle patient using group A. Remember, our patient was group O. Following the infusion of 3 ml of blood, the cannula failed, causing the pump to alarm, and at this point the nurse noticed the wrong blood was being transfused and stopped the administration. And thankfully there was no adverse outcome to the patient. Here the nurse had checked the electronic prescription for 2 units for 2 different patients at the same time and did not perform the checks at the patient's bedside as recommended. And this ABO-incompatible transfusion could have resulted in a serious acute hemolytic transfusion reaction and the risk of significant morbidity and potentially death. The next case is of a hyperhaemolysis in a child with prior alloimmunisation and antigen-E variant. This is a child with sickle cell disease who had anti-S, big S, anti-JKB and E antigen variant and was listed for an elective splenectomy and therefore had preoperative transfusion. 2 days following the transfusion, she presented with flank pain and dark urine. There was a drop in hemoglobin from 104 grams per litre immediately following transfusion to 67 grams per litre. The patient was treated with immunoglobulin and steroids. The DAT was positive and a pan-reactive anti-E, little E, was demonstrated in the ileum. This case highlights the difficulties that can arise with RH variants, which can result in patients receiving blood which appears RH compatible based on serological phenotyping. Case 24.9 is of a young man with sickle cell disease and the history of Fateha who underwent an elective exchange transfusion. 12 days later, he presented with fever, abdominal pain, and a decline in the hemoglobin from 105 grams per litre immediately post-transfusion to 78 grams per litre and then 55 grams per litre 2 days later. Anti-big S was identified post-transfusion. The patient made a full recovery. This highlights that sickle cell patients with alloimmunisations are at further risk of developing antibodies and therefore subsequent transfusion requires careful consideration. Case 24.10 is of a middle-aged patient with sickle cell disease who received 6 units of red cells over a 6-day period. Post-transfusion DAT was positive, but the antibody screen remained negative. The indications listed for transfusions included sickle cell crisis, anemia, poor increment in hemoglobin following blood transfusion. Once the hemolytic transfusion reaction was suspected, the patient received steroids and made a full recovery. So next case is of a hemolytic transfusion reaction which wasn't initially recognised, and it's a middle-aged lady with sickle cell who received a transfusion for acute painful crisis affecting her arms. A drop in the hemoglobin was noted and a decision was made to transfuse further, and this resulted in a decline in the hemoglobin to 38 grams per litre and dark urine. The patient was discussed with the regional specialist hemoglobinopathy team and treated with immunoglobulin and steroids post-transfusion for post-transfusion hyperhaemolysis. Next case is of another middle-aged lady with sickle cell disease with a history of anti-big S who had an exchange transfusion elective procedure prior to a total hip replacement for avascular necrosis. Within 24 hours of transfusion, there was a drop in the hemoglobin from 98 to 36 grams per litre. The patient's symptoms included shortness of breath, dark urine, jaundice, and anti-JKB was subsequently identified. And it just highlights that sickle cell patients are at increased risk of hemolytic transfusion reactions and the importance of discussing additional risk of transfusion if required for surgery, which should form part of the discussion on the risks and benefits of surgery so that the patient can make a full informed decision. So the next case is of a young woman with a history of multiple alloantibodies and previous hyperhaemolysis who needed an exchange, red cell exchange transfusion for acute chest syndrome following a stillbirth. The patient was treated treated preemptively with immunoglobulin and steroids, but developed another severe hemolytic transfusion reaction with a drop in hemoglobin to 41 grams per litre and an associated hemoglobinuria and hyperpyrexia. The DAT was positive, but no antibody was identified in the ileus. So in the pediatric setting, there were 3 hemolytic transfusion reactions reported in children. One was a case of a possible hyperhaemolysis in a child who had antibodies to big S and JKB and little e antigens were identified prior to transfusion. The other 2 were delayed hemolytic transfusion reaction, one involving anti-S, big S, in a child who historically had a Duffy A, and the other was a child who had an exchange transfusion with non-phenotype red cells and subsequently developed a delayed hemolytic transfusion reaction due to developing anti-big C and anti-big E. This caused major morbidity. So that's my final slide. All of these SHOT reports can be found on the SHOT website, shot.org. And thank you for listening.